Okay, welcome. Good morning, and a happy Wednesday to you all. I think we are 1 minute early, so I'll ramble on for a little bit before we get going. As you join in, if you could just pop a 1 in the chat so that I know that all of the sound is working and everything is working as it should be, including the chat, that would be really helpful. Thank you, Mark. First off the bat, no prizes for you, but my adoration forever. Thank you, Gemma. Lovely to see so many of you on the call. Brilliant. Okay, lots of new faces in the audience today. I definitely don't recognise some of these names, which is always good to see, especially in the lead up to the holidays. So thank you all for being here. I'd love to know where you're all tuning in from. That's always a question that I enjoy. I'd like to know how far north, east, south, west we're managing to get with these webinars. So that would be lovely to hear from you as well on. Just pop that in the chat as well. Everyone's thinking about it. Can I be bothered? Yes, you can. Come on, keep things going. We've not got too far to go. Anyone? Come on, I know you're there, Wendy, Lucy. Cheshire, thank you, Carl. Bridgeview Medal, Sunderland. I'm a Newcastle fan. Scotland, yes. Dorset. Okay, that's pretty north-south. All right, we can work with that. Wokingham, I won't hold it against you, Kate, don't you worry. All right, another question to keep your fingers warm this morning. With Christmas around the corner, is everyone feeling confident about putting holiday messaging on their system? Yes, no? All right, Liz. Hi, Janet. Yes, Wendy. All right, gold star to you. You've stolen it from Mark. That's fantastic. I think I've got some people waiting in the lobby. Let me just go and let them in. Otherwise, they'll be missing all my patter, and we don't want that, do we? Goodness me, what a waste. For those that aren't confident, because only Wendy replied with a yes, I will be putting a little link in the chat momentarily to help with your holiday closures and all of those that might be struggling. It's in our help centre. It's a very useful resource, so do check it out if you've got any queries around that. And if you're going, what on earth is she on about with the holiday messaging? Definitely go and have a look at the article. It's worth it. All right, awesome. Bit of housekeeping before we get going. Firstly, to say the call will be recorded for prosperity and sharing. You're not going to miss a thing if you do need to jump off. We know you're all busy and we are aiming to keep you for only 30 minutes. It's Derek today is an unknown entity, so I hope to keep to time. Second of all, we love the questions, so please feel free to drop those into the chat at any point. We'll get to them when we can. And we now know that the chat is working, so please feel free to use it at any point. All right, my name is Lucy Glynn. As you can see from the screen, I'm the community manager here at Exxon Health, and with me today we have the man with a plan, backed by data. It's Mr. Derek Measham. Wow, the crowd goes wild. Good day to you, sir. How are you doing?
Morning. Yes, doing very well, thank you. I've never had an introduction like that before, so yeah. It was,
Oh, well, stick with me, kid, stick with me. Yeah. Derek, I've been slightly apprehensive about this one, I'm not going to lie, because not many people know this because I'm so shy and retiring, of course, but when I first joined Exxon Health, I wasn't a big fan of data. Thought it was all a bit boring. If I'm honest, this is an open space, safe space, so I'm just going to share. But a year in, and I've been working with you relatively closely. I've seen what you and the team have been doing. And I have to say, I've had my eyes opened wide to data and its value. And as you said at the top of this call, you're going to give a Christmas data gift to those that join us today, which I'm absolutely intrigued about. But I do wonder, Derek, can you open some more eyes today? Are you feeling confident?
Yeah, I hope so. I've definitely got a couple of bits that I want people to take away. Actually, and one thing I hadn't put in here so far, it's just come up, is that Christmas period. So actually, yeah, in those few days, I think it's 3 days in between Christmas and New Year, just on telephony data, yeah, on average, people get half the number of calls. So you still get a significant demand over Christmas. That's an extra stat for everyone.
Very good. See, it just has them just off the shoulder. I mean, that is all relative, isn't it? Because half the number of calls depends on how many calls you got in the first place. So I guess it's not too much of a rest for everyone. But we've only got 30 minutes today, Derek, so I know you're not going to be able to cover it all. What are you going to be talking to us about?
So yeah, I've sort of split it into three. So 3 parts to this. So the first part, I'm just going to look at some of the existing reports and down at surgery level to see what the sort of insights you can get and highlight a case study from one of our practices. about some of the achievements that they've had through analysing the data over a couple of years. Second part is to sort of go out a bit on telephony data and look at some of the sort of wider national view across many thousands of surgeries and what's going on and what you can sort of see there. Then the last bit is a bit more forward-looking, and actually not just telephony data, but if you combine other national data sets that are out there, so online consultation, appointment information, then you get a whole view around access and demand for what's happening at your surgery or PCN or across your patch. So yeah, three areas to look into.
Well, I've got burning questions straight off the bat, I think, from what you've just said. So without further ado, I suggest we dive in. But just a reminder to everybody that's tuning in, if you do have questions throughout, please feel free to pop them in the chat. I will be monitoring it, and I will interrupt him without fear at any point. So Derek, over to you.
Okay, thank you very much. Yes, please do interrupt. So yeah, straight in with this case study from Peel Hall Medical Centre. The stats here, we've been using this for a year or so. So I'll dive a bit deeper into it. But ultimately, over a sort of 2-year period, they've been analysing their data and making small improvements. And the headline stats there are really quite incredible. So yeah, over that period, a 54% reduction in inbound calls and a 77% reduction in average queue time. I just wanted to touch on a few of the key stats that you can get from the standard reporting, and I'll go back to these graphs at the end. So if you go into your reports console, one of the most basic ones is actually just start with sort of inbound call stats, just to see what the volume is, to highlight the volume. Don't want to think there's just this endless demand. You can see and go back over time and see what the actual inbound volume for all calls coming in. That gives you a great insight into how you should set your system up, how you should allocate users to answer those phones. The orange line there is the sort of maximum concurrency that was achieved as well. So you can see here for, I think this is Peel Hall actually, that around normally on a sort of Monday, they have about 12-ish people logged in and answering the phone. And then that's sort of really driving some of those extra stats and benefits that you can get from it. So that's a key thing to understand overall in inbound telephony data access. Next crucial one out of 3 for me is actually looking at menu data. Now, a lot of this depends on how you've got your system set up. But most people will have at least a main menu of some description. The labeling of it is entirely sort of within the configuration, so that's how you get your reports out of it, on how you've configured it. Every surgery is slightly different, but more or less everyone kind of has appointments, prescriptions, test results, general. This is quite a standard sort of menu split. But what you get from looking at this is a breakdown of that inbound capacity to actually what the sort of patient intent was. So, why are they ringing? And this gives us some really great data to sort of drill down into and make some improvements. Probably no surprises that appointments is the number one reason. But actually then if you had another menu off the back of that and sort of explored what sort of appointments, and maybe you can divert people to other resources, then you're sort of making some improvements and chipping away at where the bulk of the demand is each time. The last standard report is the group overview. So the system is set up so calls are diverted into groups, and you can compare how calls are handled within those groups. Again, this is a fairly standard set of data for 1 month for a surgery, and you can see the sort of the patient experience, if you like. How many calls were answered, how long were people waiting for, and what else is on there? Sort of maximum sort of wait for people, etc. I think this is useful just to sort of have a look at your configuration to see if things are set up correctly, if they can be improved, if there's differences between groups. Have we matched the sort of demand with the configuration of the system to cope with that? I think a sort of recurring theme is we are doing lots to sort of try and improve to avoid queuing, but we definitely don't want to design the best queuing experience for people. So to me, it's all about using this, but not necessarily making queuing better or alternatives, but trying to just sort of get people dealt with the first time through various means. I'll touch on that a bit later. So this is from the Peel Hall case study. I mentioned a couple of these things on here, but yeah, number one to me, appointment cancellations. This tip here says, add a menu option, prioritize them to the front of your queue. You can do that, but if you just go away from this with one stat, it's this one, which is, we think, around 6 to 10% of all telephone calls into general practice are for checking or cancelling appointments. For an average practice, that's about 7,000 calls a month is the sort of average inbound number of calls per month. Potentially up to 700 calls per month are just about checking or cancelling appointment. There's things we can do in the system to sort of handle that, look after it. We do have a check and cancel feature for EMIS. It's coming for System 1 next year. Or diverting them, suggesting to people look in the NHS app if that's been configured, or other patient portals. So that's probably the biggest chunk of phone calls that you can handle. And again, just keep revisiting the data, making those small improvements, and that's a significant volume of telephone calls that you can remove from being handled by the sort of inbound reception team. There's other things you can do. Obviously, a lot of calls are from other healthcare professionals, hospitals, pharmacies, etc. Again, you don't necessarily want them cluttering up queues, interfering with the patient experience, so you can create different backdoors in. That's quite another chunk of calls that can be handled in a different way and better experience for everyone. You probably want to get those people coming through quite quickly. Patient callbacks been talked about a lot recently, but implementing that helps sort of smooth the demand out. I'll show you some graphs of what's happening nationally in terms of daily and hourly call volumes as well. Last tip on there is about adding SMS into your call flow. It might be a slight controversial one because obviously SMS costs are hot on top of everyone's mind at the moment. But actually, what Peel Hall did was went quite deep into the sort of financials around SMS and compared it to what happened if that call was answered and 4 minutes of somebody's time, adding that up over the volume of calls coming in and then just comparing that to the SMS cost. To them, it was a no-brainer to spend the money on SMS, to divert people to other resources, point them in the NHS app. So that's definitely worth considering. And again, the data sort of can underpin some of your choices there. Okay, so just highlighting again, Peel Hall. So this is the reduction they achieved. Actually, the interesting thing to me is the callbacks going down there. So I think they've got to a point now where on their system they don't have to have any callbacks because they've reduced their queuing to a point where no one queues effectively for any serious amount of time. So they've smoothed out that incoming demand enough where they have no queuing, so there's no need for callbacks anymore, which is quite an achievement and a good place to get to.
Can I just intercept you there, Derek? Because
yes.
I'm just intrigued. Obviously, the stats, if you just go back a slide, those stats are incredible. What do you think that the sort of one thing that they implemented was that made the real difference? Because obviously you've given us the top 5 tips there, and they're all great, but very, very busy people on the call. I'm just intrigued to know what that one top tip that's going to make a real difference to kind of capacity and demand is.
I was afraid you would ask that. So I think.
What's the data saying, Derek?
The data is saying that they actually made a number of changes all over the place, because it's not just about telephony data, it's about how patients are signposted to the online consult systems, the part the NHS app plays. So they were looking at their data every month, making those small changes around some of the messaging on the system, and just they have the sort of same incoming demand that all surgeries had, but they just kept chipping away every month and trying different things, different prompts, different signposting. Actually, they were one of the first to go live with our check and cancel feature, so they did take off that sort of, it was about 7%, I think, of calls for them were about checking and cancelling. So that was probably the first chunk that they did. But then it's just sort of constant analysis of the data every month. So the biggest bang to make a difference is the checking and cancelling of appointments, I think.
and I'm intrigued to know, it's almost scary to ask, but how many on the call have implemented check and cancel to their EMIS systems or found a workaround on their System 1 systems? Pop it in the chat. I'd love to know. Sorry, Derek, carry on.
Right, no, good. So yeah, next section here is about sort of general access data reporting at a wider level. I won't say too much here, but so we obviously started now sending data. NHS England are collecting telephony data. I think around 93% of surgeries have opted into that. So certainly for our customers, those that have opted in, we've been passing that to NHS England. One of the key things that we've tried to get across into the data is the definitions around the end of call status. This to us was our sort of simple view of the call journey. So starting a call, different parts of the call. So the IVR is the section where it's our automated system answering the call, playing prompts, menus, etc. And then typically you would join a queue, hopefully quite briefly, and then you'd be answered and be talking. And the top line there is the definitions for us about where a call, when a call finishes in each of those sections, what the final outcome is. And the big one that we've been keen to get across is abandoned, which is a terrible, terrible name for that part of the call. So it started when sort of IVRs were first came around, probably in the 80s, I guess. And most people implementing this call center technology were commercial sites, trying to sell things. So to them, if someone left without talking to anyone, you didn't have a chance to sell them anything. So I think that's where the term abandoned came from. And in those days, abandoned was definitely bad. But for most of our setup, I think, abandoned calls in the IVR, we're signposting people elsewhere. There could be menu options that go off to other third parties, prompts that tell people about different parts of the system or different places to go for help, pharmacy first, perhaps SMS requests to give them access to forms to fill out data. So we still have stuck with the official call center definition. They are abandoned, but for us, abandoned is normally a good thing. So it's we probably need to change the name there, but we're still reporting on abandoned calls. But yeah, probably the more abandoned calls you have, the better. That sounds a bit wrong.
That's a good headline. So abandoned, good.
Yes.
Excellent.
Yes.
Okay. Thank you.
Yeah. This is just a bit of insight over the last month, November. This is from across over 3,000 surgeries. And it's probably typical of a lot of surgeries, although we are seeing changes, actually. So there'd be no surprises that Monday, 8 a.m. is the busiest day. The thing when we first started looking at this was just what hit us was just the unbelievable volume of calls that's coming in. You really are all operating mini call centres with the inbound volume of people that are trying to access GP surgeries. The bottom left there is the hourly breakdown of calls. And I think what a lot of people are starting to achieve now when looking at the data and seeing improvements is really smoothing that out. There's obviously a high demand that comes in first thing in the morning, and that's hard to deal with. You can't have the right number of users to prepare for that all day long because it doesn't last all day long. So we really recommend looking at this sort of daily breakdown and doing what you can to try and smooth that out, which again is looking at the intent of the calls and seeing what's going on. And if you can get that consistent across most of the day, then I think you're onto a good thing. So this was just an interesting bit of data that we've been sort of working on. Again, this is nationally, just across all of our system, but it's highlighting sort of repeat callers, or they're not necessarily people. We just know them from the phone number they're ringing for. So if it's a mobile number, it probably is one person. There's a slight caveat in this data. Things like pharmacies and hospitals are obviously ringing multiple times, so it's skewed slightly. But a lot of this sort of repeat caller demand is from the same people. It's kind of your classic sort of 80-20 rule here, actually, where 80% of your inbound calls are probably from about 20% of your people. So that if you go to that bottom right graph there, you can see that the top 10% of telephone numbers account for over half, 53% of all incoming calls. To me, this is an area that really we should be exploring more, because if you can then handle those people in a different way, or maybe be proactive. I'm not sure what the outcome is, but they're accounting for 80% of the calls, that top 20% of people. So there's really a lot of data there to go at to see how you're handling those patients and what can be done about it. Okay, on to the last section now. So this is all new. Nobody's seen this before. We've not shown that. We just started talking about it.
We should have had a drum roll. Just popping it up on the screen. Okay. Surgery Insights. Tell me more.
Surgery Insights. So telephony data is great. Obviously, we love it. There's an awful lot you can do, but it's not the only bit of data that we all have. So what we started to do is combining telephony data with all the other data that's out there. Telephony data is being collected nationally now, but a lot of data has been collected nationally for a long time. It's available. It's out there. It's available for everyone. So what we're doing is starting to look at telephony data alongside online consult, alongside chatbot data, if you have Surgery Assist and that chatbot routing, alongside NHS app data, appointment data, and some of these other national data sets like workforce and patient registrations. And it's only really when you start looking at it all together, you get a true view of access and how you can improve it. So we are all massively excited about what we can provide here. I'm going to actually go to a live report that's across the national data, and for a subset of people using our system, just to highlight what's going on. Let me just work out how I switch back. There we go. Hopefully you can see that. So that's the live report. Okay, good. So yeah, lots going on here. Still very much in development. But this is the key one to me that highlights all of the sort of access requirements. So we split it here. So there's the main chunks on this main graph are monthly appointments, which is the blue one. Orange is monthly telephony, and the green is online consult. So I think this is a pattern that we've seen before. So on average, 7,000 incoming calls per practice, and I think the average online consult is about 700. So it's a sort of interesting stat there about where you're focusing your energy and time into dealing with the demand. I've just looked at the time, so I'll speed up a bit because I really want to get some questions from people. Actually, I've got a question for someone based off this. So there was obviously a huge jump in appointment data, appointments last month. I think it was 38 million GP appointments. I haven't yet drilled down into why that is. So if anyone knows why there was a huge leap in appointments reported last month, I'd love to know.
Yeah. There you go, folks. Pop it in the chat.
Question. Good. So this is chatbot insights, which again you get a bit more detail if you're using Surgery Assist chatbot. Telephony data we've just been over in general. This is kind of the national view over the last year, so you can see volume of inbound calls. Abandon is on there, so actually abandon is going up, so that's a good thing. Started to look at some of the appointment data, again all nationally available, but hoping to combine it because it's only really when you start tweaking individual points and you might be able to derive some interesting insights somewhere else. Online consultation data, the national data is good to see. It's slightly limited in some of the outcome. We only really split admin or clinical, but again, you start comparing that to telephony data and the other access points, it becomes a useful reference to know what's going on overall. NHS app, obviously adoption and use of that is creeping up, which is a good thing. We really want to encourage as much use of the NHS app as possible. We would like some of the sort of check and cancel and things like that are features on our system, but really NHS app is a significant tool for the country, I think, to reduce some of that incoming demand across telephony. So yeah, we're a phone company essentially, but we are happy to have less phone calls, and we are sort of working on these other areas like Surgery Assist to try and reduce some of that demand as well. And yeah, we go into workforce and some of that patient registration. But again, we've sort of uncovered some interesting things about the size of surgeries and patient numbers and workforce allocation that really sort of gives some indication about sort of optimum levels of staffing, etc. So it's not a straightforward picture, but you start to combine. This is all the data that's available around access into primary care, and then we should be able to make a difference. And we are just sort of starting on this journey, but very happy to speak to people and talk people through it. We've been doing that with a number of surgeries, so the more we have, the better.
Well, I think York Medical Group might be interested in talking to you about it as well. But David has got a specific question. Is Surgery Insights a separate product?
Surgery Insights, it's still in development. It's kind of at the moment it's bundled in. It's going to be bundled in with Surgery Assist, the chatbot, just to give you some of that insight into the chatbot data. I suspect we probably will separate it out on its own as well, because I think, especially with a few changes, it will become super useful. So yes, it will be a separate product at some point next year.
Exciting. Okay, so hopefully that answers that one for you, David. Equally, David and Chris have got a couple of tips for you on why the appointments spiked last month. Flu. I think it's probably a strong argument. Yeah. And Graham's got a great question, actually. He feels I should know this already, but does a patient call that results in them requesting a callback, is it labelled as abandoned?
No, that gets labelled as a callback, actually. So yeah, in our data, that's a callback. So yeah, it's a bit of a difficult one. We did actually go down the route of linking that initial call to the outcome of the callback in some of our data reporting last year, but we're changing that now because that gets horribly complicated. So yeah, the inbound call is a successful call that results in a callback. So yeah, that's not abandoned.
Okay, see, confident, strong answer, Derek. Thank you, because this misnomer around abandon has been plaguing me, I think, for about 6 months. So I'm really delighted you're here and able to explain it. And David's just clarified it's flu clinics, not people with flu. So there we go. I've got a question for you. If anyone listening today isn't feeling particularly confident, I guess, with the management reporting that's currently available within Surgery Connect, do you have any top tips for them as to where to start?
Yeah, I suppose it's those first 3 areas, actually. So I haven't got the presentation up now, but yeah, just looking at the total inbound volume. So that gets broken down by day, but also per hour as well. So you can really see where the demand is in your surgery. And we're certainly seeing most surgeries are all different from each other, and the demand is different. So just understanding that where the peaks are coming in. The menu data, to me, I think is crucial. It's kind of a it's not used enough in terms of how people are utilising their menu structures, and labelling it also is correct. And you can look at, again, where the incoming demand is actually going and what you might be able to do about it. So yeah, it's probably those 2 actually I would look at, and that's a good starting point.
Excellent. I'm also going to use this as a shameless plug for the Academy, because there's a lovely course in there that is a good starting point that covers some of the basics you've talked about today, Derek, as well. So I've just popped a link in the chat for anyone that's not seen the course. Please do dive in. It's a free resource and one well worth utilising. One final question from me. I don't think there are any more in the chat. Please pop them in now as a last chance if you've got any, but a burning one from me. A little birdie told me that there was even more in the pipeline with regards to data and reporting. Are you allowed to tell us any more at this point?
Probably not, but I'm happy to. So yeah,
safe space, Eric. Safe space.
Safe space. Yes. No, we're always looking to improve, and actually the data analytics is moving on heavily, as is a lot of technology these days, as you'd expect. So really, the thing, very early for us, and it might be a while before it appears in the product, but the way data reporting is going is really into what they're calling conversational analytics. So instead of being able to configure your own dashboards and having that real grasp of what's going on and maybe having to be slightly technical, the way things are going, you'll be able to chat to your data reporting tool and maybe ask it things like, can you tell me what my overall incoming demand across all access routes is like every Monday for the past 2 years, please? And up will pop a graph of everything you've asked for.
Goodness.
So yeah, we're looking at some of the tools now. We're working hard on our data model in the back end to plug all that together. But things are moving on quickly. So I really hope that's somewhere we get to quite soon.
And I really hope you haven't overshared, but I'm quite excited about that. I think was the right response. All right, well, there doesn't seem to be any more questions in the chat, so I will wrap up. That is it from us today. We are out of time. Right on time as well. So congratulations, Derek. We hope you've enjoyed it, and thank you all for your participation. Our next webinar is planned for the 15th of January, where we will be diving back into Surgery Assist to talk about some of the really exciting developments on the horizon. So do look out for the link for that. If you'd like any further information on anything we've spoken about or have any pressing questions that we haven't covered, pop your ODS code in the chat right now and we'll get your client relationship manager to reach out to you. We will of course make the recording available to all registered attendees in the next couple of days with all the relevant links, and we hope to see you all here again next month for more. In the meantime, on behalf of the whole Exon Health team, have a happy and healthy December, a fantastic Christmas if you're celebrating. Thank you, Carl, and we will see you next month for lots more. Take care. Have a good Christmas. Bye-bye.
Thank you. Bye.